Welcome back to part 4 of our discussion of neuropathology conditions. Okay, so we're kicking into Parkinsonism. So this is a general term that refers to movement difficulties such as tremors, bradykinesia, and rigidity, but it's not the same thing in Parkinson's disease. So with this one, they have early falling, early dementia, and early hallucinations, and it does not respond or barely responds for just a hot second, but not really, to levodopa therapy. Remembering that Cinemat drug was like the drug to treat Parkinson's disease. So many of the attributes that we associate with late stage Parkinson's disease are present at the get-go for Parkinsonism, okay? So you can see why they're named similarly. They are similar, but they end up playing out very differently. There are a lot of different types of Parkinsonism. So many, some of which maybe you've heard, some of which maybe you haven't heard. And a lot of it exceeds the scope of a basic conversation around neuropathology. So there's one Parkinsonism that we are going to focus on, and that's Lewy body dementia. So Lewy body dementia, I think, came a little bit more into people's awareness when the actor Robin Williams passed from this condition. So this is a progressive degenerative brain disorder, and it's notable in its presentation for elements of dementia, including psychosis, and then all the features of Parkinsonism. So 80% of your folks with Lewy body are going to have hallucinations, and these are often high detail. Sometimes they're not necessarily frightening. I've had a nice conversation with a patient who was actively having a hallucination. They were hallucinating a woman sitting next to me. They could describe her hair, her eyes, her clothing, and said that she was just sitting pleasantly next to me listening. So they're not always frightening, but they often are. So it's not unusual for people to cry out in fright because they're seeing what they think are ghosts or something. How does this happen? It's abnormal deposition of a protein called alpha-synuclein. So you can see that this is different from the etiology of Parkinson's disease. If it's caught really early, it tends to be a little more responsive to certain medications. Otherwise, though, this is a fairly rapid degeneration once diagnosed. So once it starts in, less than a decade, a lot of times. Let's move over to another condition. So this is another basal ganglia condition. This is Huntington's disease. So this is a progressive condition that's genetic in its basis. It's notable for abnormalities of movement, dementia, and personality disturbances that are often quite striking. Among the movement disorder attributes, it's notable for something called chorea. This is a purposeless and involuntary movement. So with chorea, I'll play the video here in just a second. In strict definition is an excessive spontaneous movement with irregular timing. It's not repetitive, and it's very abrupt. It just kind of jumps out of nowhere. Sometimes it varies to like fidgeting movements of the hands, but mostly it's known for its dance-like continuous flowing movement and large high amplitude movements that can be practically violent. So here we have an individual who has been kind enough to record themselves. She's telling you about her condition and what it's like to live with it, so later if you want to listen, that's worthwhile. Note the movement disorders on her face, her hands, her trunk, her neck. That's her own muscles sending her backwards. Yeah. Huge motions, look at that. Well, she's trying to talk. She just wants to lay in bed and tell you about her condition. Look at the fingers. This is another one of those conditions where back in, the medieval ages, they probably thought someone was possessed. Yeah, extraordinary. Simply extraordinary. And very generous of her to share her condition, because socially this can be really, really tough. Everybody stares at you type thing. And she just wants to talk. Oh, those fingers. So again, the abrupt, irregular movements, sometimes kind of dance-like, and it can be kind of almost violent scope of movements, like the scale of the motion, so they can sucker punch you accidentally type thing. So the clinical presentation is notable for the chorea, for the high tone, speech and swallowing difficulties, memory issues, personality changes, and intellectual decline. Interestingly, in terms of personality changes, one of the iconic early presentations is they start to become kind of a jerk. Actually, they engage in a lot of insensitive behaviors. It's not unusual to hear that divorce has happened. So the personality changes are often striking. So somebody who was amiable and easy to get along with suddenly becomes somebody that someone no longer wants to be married to. So like I said, striking personality changes, intellectual decline, and then memory in combination. So all of that together right off the bat, and if you don't have the movement stuff right off the bat, it can just seem like they're becoming a mean person. So, but it's the diagnosis. So this is an autosomal dominant mutation. Okay, they actually know what this is from. The gene is called Huntington. A mutation causes issues. Okay, so the result is that the basal ganglia and the cerebral cortex degenerate. Both sexes are equally at risk. It crosses all races. It tends to set in middle age. So you can see that this is an age in which people get divorced, right? They've changed as people, and now their partner's suddenly mean. There you go, right? So typical age is middle-aged. This is one of the things where you would hopefully know if you had a family history of it, but if you didn't, this would be a reason to get genetic testing before choosing to have children. So pathogenesis, again, this is an issue of the basal ganglia. A different portion of the basal ganglia deteriorates here. This is striatum, and the result is that you have too much dopamine. So the result is excessive movement. So this is the opposite of Parkinson's, and that explains the chorea. So it's like bradykinesia on one end, chorea on the other. How do they diagnose it? Symptoms, clinical exam, family histories, that'd be the genetics as well. And then the MRI, and on MRI they're going to have really enlarged ventricles. This is partially from atrophy of the cortex. Treatment, there's only one drug that treats it, but that's a lot, so I'm not going to go into it, but it is worth noting from a purely psychosocial element, they end up giving these individuals some of the most powerful antipsychotics on the market, one of which is used in the treatment of schizophrenia, sometimes used in the treatment of Tourette's, which helps, in theory, reducing unwanted movement, but it has, unfortunately, the effect of suppressing wanted movement. And then it can cause other forms of movement disorders. It's almost like swapping one issue for another. But there really isn't a good treatment pharmacologically for chorea. So these folks just kind of end up, haloparadoling themselves into just staring into space. So they really need physical therapy to help keep themselves from falling all the time and to assist in tone management. And it's really important to get in there early. This is a progressive disease. It will eventually end up with making someone bedridden. It's not unusual to hear in late stage they need to consider a second mattress on the floor because their chorea is so powerful that it can launch them out of bed. Yes, that's a thing. But all I expect you to understand is the early presentation to help catch it. So the postural and balance changes, chorea, particularly affecting the hands, weakness and mild cognitive impairments. At this point, you can still try to restore some of the original function. As it progresses, though, you enter a stronger form of it. The individual in the video there is probably veering into the middle stage of Huntington's. Prognosis is not good. It'll shorten your lifespan. Unfortunately, in late stage Huntington's, the chorea tends to subside, and it's replaced by lack of any movement. So once they get further in, pneumonia is a very high risk, and they end up with dystonias, so alterations in tone, and this makes eating and swallowing difficult, and so pneumonia is a real risk for them. There's an inverse relationship between age of onset and disease progression. In other words, the younger they are, the faster the disease goes. It'll shorten their lifespan a lot more. So that individual in the first picture I showed you, that's an individual with juvenile Huntington disease. It kicked in her teenage years, so it drastically shortens lifespan if it comes in earlier. If it comes in later, then you do have longer. All right, team, I think that finishes it up.